to have surgery.
Oh, yeah. So everybody's tested.
Yeah, within 72 hours. Otherwise, they will not let you come in.
Okay.
That's the
Yeah.
policy.
For us, we did that initially, and then for our day surgery cases, we haven't had to do that anymore.
Yeah, for laser is not a problem, but or for injections for retina guys, but for outpatient surgery, they have that requirement until further notice.
Okay. And are you changing your preferred glaucoma procedure at all, or are you?
It's interesting, you know. I don't want to speak too loud, but I haven't really. Maybe it's because the kind of clients we get in this. There are a lot of a good number of African Americans who are very complex surgeries. You know, this whole eye stent. You know, the new generation. I don't hardly do it. I mean, I'm doing a train wrecks. You know, on 3 or 4 meds. So I'm doing a lot of trabs and tubes like I normally do because they're so maxed out. But I am doing a lot of hydrus and Cahook dual blade and the canaloplasties.
Mm-hmm. As standalone.
Yeah, or combo. Yeah.
Okay. Yeah, it's interesting. You know, we often talk about what's the ideal procedure during a pandemic. You know, and it's one that, number one, minimum postoperative follow-up, low complication rates. You know, try to get people off their medications, and it all kind of leads toward some of these newer procedures. You know, and you know, it sometimes it takes a pandemic for us to remember what you know, what we need to be, where we need to be at versus traditional approaches.
Yeah.
So it has been interesting procession here. We've got people joining us. Let us know where you're coming from. Indonesia is always here. It's nice, you know. We get folks from around the world. Some of our dedicated attendees. I know it's, you know, there's so many different things happening now with people getting back to work and webinars that people are busy, but we do get a nice group of people from around the world, which is nice. Pittsburgh, Curitiba. I don't know if I'm not sure if you're going to get anyone from Cleveland there, Shakeel.
You're all sleeping. I
We
give
have
credit
some
to.
we have some veterinarian ophthalmologists as well, by the way,
Wow.
who often join us as well, which is kind of neat.
Hey, do they do iridotomies on dogs? I know they get acute angle closure. I wonder if they get that issue.
Well, the problem with dealing with the iris on dogs, man, like their iris are so reactive that, I mean, you know, you touch the iris and they just get this terrible inflammation. Maybe Joe can tell us that. Who's here? Let me just put the YouTube link on for those of you who want to go to YouTube. You do have someone from Cleveland. You got Matthew Nicholas.
Yeah, he was my resident in Rochester, man. He's a diehard. He actually is writing up a paper on this cases we're discussing today. Actually, hey Matt,
Nice.
good to see you, man.
Is he in Cleveland?
He's doing his fellowship in retina.
Okay.
So he just graduated in I think end of June in Rochester, New York.
So Joe just said, true, lots of inflammation and fibrin when you deal with iris, worse than horses. Jonathan Lass is here representing.
Yeah, he's our emeritus chairman. It's,
Great.
That's awesome.
So you've been in Cleveland now for how long? How many?
1 year. 1 year.
1 year now. Okay.
Yeah.
And you find how different is it from Rochester, just the city?
I think, you know, it's just it's hard to answer that question because I was getting my groove getting in here, and I was renting into an apartment for the first 6 months. We moved into our new home, and bang, COVID hit, so I was gone nowhere.
Okay. What timing?
It looks nice, you know, but there's no baseball, there's no basketball, there's no football. Everything's on hold. Even the zoo is closed until I think they open now. But it's interesting.
You also came at the wrong time, man. You came after LeBron James left.
I know.
Like this.
But you know,
your timing was not right.
Hopefully he'll be back. You know, when he getting older, I think he's got roots over here.
I know. And we'll be introducing everybody shortly, but we have Vanessa. Vanessa is in California. She's so kind enough to tune in at 5 a.m. Now, Vanessa, what time do you normally get up at?
On a weekday, around 8. On the weekends, I'm gonna keep it for myself.
I don't blame you. I don't blame you. I know the weekend, you know, it's been difficult to figure the right time to do these because we've had, I did a big survey, you know, and we had like a split vote. We had like evenings for most people in North America, in South America and Latin America. Then we had, you know, Europe, and I see Vivian is here from Singapore, you know, doing it like on in the morning, on the weekend. So we're kind of all over the place. So we'll keep on, you know, moving around perhaps and see what the best time is. But I certainly know, I mean, the first few days, you were there, I think, Vanessa, the first few days of the pandemic when we started this up, I mean, everybody was locked down, nobody was moving. So everybody was like, just okay. And everyone was thirsty for knowledge. So it was like, it got pretty busy. I remember we had, our Zoom account got overloaded. We couldn't handle enough people. So it was pretty amazing. And so you were telling us about California, like what's happening now. You're saying you're kind of more locked down at home though, eh, as far as what's happening right now. Sorry,
I
Vanessa.
lost you there for a second. Sorry, guys.
Vanessa was just saying that she's you know, based on what's happening right now in California, she's been staying home a lot.
Yes. Stay safe.
But I mean, are people staying home a lot in California, or is it still kind of you know, business as usual?
It's surprising when you go on the street, you see a lot of cars and a lot of business as usual. I went to Costco yesterday for a quick in and out, and it was packed. So
Yeah, man, it's just so hard to know what's going to happen, right? You know, I mean, I don't know. I hope we want this to be over, man. Like
yeah.
it's it's getting to be a drag, and I understand the complacency, right? You know, with kids and everything else, man. We're like, our kids are like, we want to go out and hang out, and everyone has their own bubbles, right? We got bubbles here, right? You know, you stay in your own bubble, but then you're with one bubble, and then you got another family members in another bubble, and you kind of hang out together, and then your bubble gets like this, and these bubbles are starting to get all over the place. Don't know what to make of it, you know.
I want to get too bubbly.
Yeah, too many bubbles, you know. But it's interesting as well with patients. I don't know, Shakeel, have you found that? I mean, do you find some patients are not, you know, even though they have bad glaucoma, they're still not wanting to come back for visits or get assessed, or do you find it's not as much of an issue?
The tough part is that, you know, you're dealing with an inner city hospital and also suburbs that go to different settings. You have sometimes patients who are post-op and they don't show up until 4.5 months later after a tube. I mean, come on now. And they call them to come in. The guy came in the other day and he had literally a plate, you know, that had migrated anteriorly 2 millimeters from the limbus. His pressure was still 6 when he was 54 and he came to me. He shows up 4.5 months later. And I told him to come back in. I saw him at the 2-week post-op. He was on Pred Forte every 4 hours. He was still taking every 4 hours, 4 months later. I mean, I don't know what he did to us. The plate's high, you know.
He was compliant with the drops, though, at least. That's good to know.
I mean, I'm like, what do you want me to say? I'm glad your pressure is 6, but you know, he was upset. I said, where have you been, sunshine? You know, you should have been here, you know. You know.
What I'm finding is, like, I think the glaucoma patients and the ones that are like complex, I mean, they generally have been wanting to come back. Understandably, they're quite concerned and anxious.
Yeah.
Cataract surgery, on the other hand, I think a lot of patients kind of decide to just put it off a little bit. Not everybody. I mean, a lot of people do want to get things done, but you know, in Canada, we're not too bad. I mean, our numbers have really come down. We've flattened things out. We see a few little, you know, clusters here and there, but everybody's really kind of just, you know, kind of in a kind of you know, a steady mode. The big thing is going to be school, right? That's kind of the big question we all have. And I don't know what the right answer is, man. It's going to be like, you know, who knows what's going to happen in the school year, and that's going to happen.
Guys, but I think, you know, Doctor, I think your Justin Trudeau will keep the borders closed till September. I heard.
Yeah. We're
Americans out, man. New York and
it's really eerie seeing the Niagara Falls and seeing the bridge being empty. You know, normally they're like, it's packed.
My daughter showed me a very, very funny picture. it's an aerial view of the Niagara Falls with a little the mist, made of the mist, I think it's called.
Yeah.
And if there's two boats going past each other, and the American side is packed like sardines, all got these blue umbrellas on. Then on the Canadian side, like one guy in the roof on the trailer.
Yeah, it might be a little bit. It's a little representative of what's happening. Well, I think we'll get started. I want to thank all of you who've joined in on Sunday morning here for our Prism Eye Rounds. We've been doing this virtually live, on a weekly basis, or sometime actually even twice a week during the pandemic. We've moved it down to once a week, and we're really thrilled to have Shakeel, Shareef to join us, as well as Vanessa Vera. Shakeel, I'm just going to put my slides up here, okay, just to introduce you both here with us. And I also want to thank Matthew Brink, who's with us as well. Matthew is speaking of the U.S. border. Matthew's come to us originally from South Africa, but did his training in Baltimore, and you just came a few weeks ago, and you just now finished your quarantine, right, Matthew?
Fresh out of quarantine.
Yeah, so if you want to know what a quarantine face looks like, look at Matthew. That's a quarantine face.
He's smiling.
He's smiling. He looks rested. He looks better than me, certainly. So I mean, how was it, by the way, being quarantined for 2 weeks, Matthew?
You think about it, and you think, if the whole world could do this just for 2 weeks, would be rid of the problem, right? But I can see how that would be challenging. Not easy.
Oh yeah,
What does it mean, Matthew? And what was your quarantine like? Did they deliver the food to you, or what?
Thankfully, Instacart and whoever else, there's all sorts of ways to get food delivered. So, I mean, that was a savior. But they take it really seriously. So you got to do it all online,
Mm.
Yeah, they take it seriously here in Canada. I mean, I remember I was talking to our fellows. I mean, Patrick is our other fellow from the U.S. who came up. And I said, you know what? No one's going to just go for a walk at least, or do something. Get out there and, don't see people. Just go for a walk on the street. And I think that Patrick was telling me, well, yeah, they have a fine if you break quarantine. Like, it's a pretty ridiculous amount or something if you break quarantine.
$1 million.
$1 million.
Up to, yeah.
Up to $1 million if you break quarantine. And that's like, I said, well, what about just walking on a sidewalk? Just no one's around you, right? But then after that, I kind of said, well, maybe you should actually stay home. That's hard though, man. Good for you for doing that. We look forward to seeing you on Monday.
Yeah.
So today is August 16th, 2020. It's hard to believe we've been in this for let's see, April, May, June, July, August. So 5 months. And I think things are getting better in some places. Unfortunately, there's still challenges in other places, but I appreciate everybody being here around the world. We do have credits from our Royal College, as well as equivalent AMA credits if you're looking for credits. And we will continue to do our rounds. Next week, we have David Lockington from the UK, who will be joining us on cornea. We'll talk about corneal issues and melts. And we also have a presentation on IOL complications. So that will be on Saturday, back to Saturday. So stay tuned for that. Our guest speaker here is Shakeel Shareef, who is a professor at the Department of Ophthalmology at Case Western in Cleveland. He directs the glaucoma service there. He was recently at the University of Rochester and now has been in Cleveland for a year. As I was joking with him earlier, when LeBron James left, the big superstar from the Cleveland Cavaliers, Cleveland was able to bring in another superstar, Shakeel Shareef. So the city didn't lose a lot of talent.
A different sport, though.
The glaucoma patients are happier that you're there. Maybe the basketball fans are maybe a little bit upset. Shakeel, I just have one disappointment. In anticipation of you joining us here, I grew my beard. Shakeel is known to have a really nice, you can see that, very, full, hair, facial hair. I just grew it for you, man, and I'm just disappointed that now you've trimmed a little bit there. So
I came out of COVID, Ike. I mean, I'm back to work.
I know, and I went the other way during COVID, out of control. So, but thanks for being here, Shakeel. I think we're all going to really enjoy your presentations. Your perspectives are always very thoughtful. Very, very skilled surgeon. Shakeel focuses in in highly complicated procedures, glaucoma and the anterior segment. And he's visited me a few times as well. He's a really good friend and a great guy. So thank you for being here, Shakeel.
Thank you for having me.
I also want to thank Vanessa Vera, our guest panelist, who originally is from Venezuela. I had the pleasure of being with her for a year as a fellow just a few years ago. And I always joke around that, when the fellows come in, I usually kind of tell the fellows what to do, right? But when she was a fellow, she basically told me what to do. It still does. It still does. But Vanessa's really been active with MIGS. She's been very involved with the Zen development, and many of you have seen her work, her publications on best technique, which has really been critical with MIGS procedures. MIGS has been around, but optimizing the right procedure and doing it right, I think, has been what our next and our current challenge is. And she's been really involved in that. She stays very active in the medical community and always on our chats and discussions, has a lot to add. So Vanessa's here, and we'll see why, because Vanessa has done some, I think, really probably some of the most pivotal work in the area that Shakeel will be talking about as well. And as we said earlier, she's currently residing in California, and currently sounds like she's pretty well in lockdown there. So that's great, excellent. So I will stop my screen share here, and Shakeel, I'll give it to you. And Shakeel has a few talks. I think you have 3 different areas that you're going to speak on, and Vanessa and Matthew, will join in, and if you don't mind, we may throw out some questions that come up. There's Matthew, I'm going to ask you to just monitor the Q&A line and the chat group. Those of you that have questions, please feel free to ask them. I already see some stuff in there. I see David Murphy's here from Arkansas. We may have to get that question answered later on. He's got a question there. I haven't been able to read it yet from last week. Great, good to see David here. Thank you. Shakeel, are you able to share your slides there?
Yeah, let me do that.
Vanessa, thank you again for being here. It's 5 in the morning for you in California. I know it's early, man. Thank you.
I really appreciate Ike for inviting me today. It's exciting to be here. I have really the credits due that he
blinded by the light, wrapped up like a douche, another runner in the night. Blinded by the light, wrapped up like a douche, another runner in the night. Blinded by the light.
Let's move on here. So blinded by the light is one thing, but I was also blinded by the sight. And what I mean by that is that I was recently, at the American Academy last year, and I met Ike here before my annual surgical gonioscopy course. And I said, wow, that's great. But, so that was around November of last year, I believe, or October, November, I think, in the Academy. And then I went to Best Buy with my son. I was blinded by sight. I said, holy mackerel, what the heck is going on here? Dude, I think I found Ike's, long lost, American counterpart. The hair, the look, it was like so cool, And he didn't have no idea, nor does he to this point, that I actually took a picture of him. He's diving with my son over there. Look, he's got that little the Lion King look. Is like, yeah, I'm an Ike follower. Maybe he is. I don't know.
Well, Shakeel, I can tell you my hair is even longer than that now. So it's crazy.
Well, he's taken after you. He's a little younger than you, But I wanted to share a case that hopefully, and of course, please chime in. I basically, this is a fresh new case I have not presented in this detail. So I have a lot of updated literature, and, chime in anytime you want. I got some esoteric stuff here as well, but I think it's just the idea is to, to have a dialogue here, and that's my intent. I've also have some lead-in questions where you can pop in and chime in as well. So this is basically, in a nutshell, no political, intent here, but in a nutshell, we had a patient come in who's 58-year-old female who complained about halos and around lights. Good vision, good pressure, pachymetry slightly thin, and she basically on gonioscopy she had appositional angle closure. She was a PA, S patient, PAC patient, and on imaging that confirmed her angle closure. She had normal nerves, so basically she wanted something done because it was obviously causing her issues. So I performed the uneventful YAG laser peripheral iridotomy bilaterally. So she comes back a week later and starts complaining like, you know, doc, I see a white light towards the nose outdoors. The light moves with my left eyelid only. And she didn't complain about it in the right eye. So when I performed gonioscopy on her, her angles are wide open. I could see pigmented TM pretty much around the eye, a little bit of scleral spur. And basically I said, you know what? Why don't you try some sunglasses when outdoors? Come back in 3 weeks. And this is, of course, from the Johns Hopkins group, and I think it's published in the Blue Journal now, but the Zabardust et al. Pointed out that, you know, these linear dysphotopsias typically resolve between 2 weeks to 6 months. So I figured, hey, let time to heal, and hopefully she'll get better, and have her come back in a month. And that's the month that I think cut off that Vera's paper had about looking at these outcomes in these patients, right, for new onset dysphotopsias. So
yeah. One question, Shakeel, it's something interesting that you mentioned. She came to visit you because of the halos, or was that a finding during your medical examination?
She complained to me preoperatively of halos, and and she wanted something done about it. And they actually resolved, but this is 1 week later, she's complaining about a new onset of a visual phenomenon, as pointed out here. So this
you thought maybe the halos you were considering maybe the halos were perhaps some intermittent IOP elevation?
Yeah, because she had pretty much appositional angle closure on my assessment,
okay.
And she'd been having it for a while, and it was, you know, very highly suggestive of, you know, subacute IOP elevation. And so I offered it to her, and it resolved her halos in the right eye, but the left eye had a new onset that we're going to talk about now. Okay. And this is her photomicrograph showing it's kind of hard to see, but this is another important point I want you to keep in mind. Very small iridotomy here at 9:30 clock hours, maybe close to 10 in the right eye. And notice its location in relationship to the upper lid margin. Then the left eye, you can hardly see it here. Look at this. She's got this arcus going all the way around. And I'm trying to at least get a photograph to show her iridotomy, which is more around 2 o'clock. But the way to enhance this actually is to do close-up magnification. You can see it at 9:30, and now you can make it out. See, it's like an inverted, almost like an inverted prism in the iris. And then when you retroilluminate, you can clearly see on high mag is kind of, you can see here in the right eye, and the left eye, you can see it very nicely here. She has an exaggerated lid excursion, so she's complaining about this. So when she came at 1 month, the symptoms did not go away. I see a white light now inferiorly in my left eye. So it seems to be a phenomenon that's progressing, right? She's seeing a shift in this image from the nasal aspect to inferiorly. And she points out that if I lift my left eyelid, the phenomenon resolves. And so it's important that, you know, when you look at the literature and these kind of patients that come with these kind of complaints, you want to make sure that the visual aura is related to the iridotomy and that something else is not going on. So I was a bit concerned at 1 month. I want to make sure, is there something else going on? You know, she's in that late 50s, and I did a more thorough history. She denied any history of any ocular migraines or any history of that nature. Gonioscopy, again, the angles were essentially open to the pigmented TM. And I did a dilated examination to rule out any type of retinal pathology. So she didn't have any retinal detachment or a PVD or retinal tear to suggest, you know, the symptoms she was having. And then if you look at her carefully, it pretty much goes along the line of your paper, Ike, that, you know, when she has an exaggerated opening, you can see that her iridotomy is very clear of the lid margin, but it clearly bisects the lid margin here in her normal resting position in primary gaze. So clearly something is brewing over here. And so at this juncture, I bring up Vera's paper, which very nicely points out what's maybe going on here. that we're dealing with light rays coming and striking the tear meniscus, which is basically your tear prism, which is basically an inverted prism base up. And at least in the literature, from what I read, the tear film meniscus actually is slightly concave on its surface. There's a concavity to it. And what basically is happening is that the light hits the base up tear meniscus and is causing a refraction of the light to the peripheral retina, and the short distance causes a relatively focused image that the patient can perceive. So what I did at this point, if you just bear with me, I went into a little bit of optics here. I wanted to understand, so don't go crazy with this, but I actually made a customized, this is my illustration. I didn't do a cut and paste from the internet, but what is a prism? And this is from, actually I got this from the requisites in ophthalmology, and Morton Smith, who was a ocular pathologist back in WashU. He was the first author on this book. But in the chapter on prisms, what I learned was that a prism basically is a refracting material with non-parallel faces that's triangular in cross sections, an apex and a base. And light, when it hits the surface of the prism, it actually is refracted at each of the surfaces that it exits and enters. And I'm going to give you enough here as a background to understand this patient symptomatology. I'm not going into something that's kind of, abstract here. So refraction occurs first to the bending of the light rays as the light enters from one medium into another. And this bending of light is due to the fact there's a change in speed of that light in the different media. The take-home message here we need to keep in mind is that all of the light overall, the cumulative light, bends towards the base. However, from the patient's perspective, when the patient's looking out, that image, that virtual image, is actually displaced towards the apex. That's an important point number one. The second phenomenon that I found relative to this case was that when the white light hits a prism, it undergoes a process of dispersion, which from what I understand is a splitting of the white light into 7 different colors. And I've listed them here by their color letter, R for red, O for orange, Y for yellow. And the take-home message here basically is that colors with short wavelengths are refracted much more and have a greater angle of deviation than those that are refracted less. So here in this part of the spectrum, around 400 nanometers, the blue, indigo, violet. Indigo, I learned from my wife, is dark blue, so I learned something. But blue, indigo, violet really bends the light much, whereas the red light is not bent as much. So those are 2 things I want you to keep in mind when we go back to this here now, to try to understand now. So you can see that a light beam hitting the apex, it's directing the light towards the base, which is the superior retina. However, we mentioned that the image, the virtual image, is displaced through the apex, and that explains the inferior dysphotopsia by this patient and all the literature that we read about in patients who have a superior LPI. The second thing that from what we just showed with optics is there's a perception of blue colored lines in the literature. And that, again, that's not surprising from what we just discussed with the greater refraction of the shorter blue wavelength. So for example, in the paper by Murphy et al. In 1991, he looked at 13 patients who presented with monocular symptoms. And he noted that many of them noticed a bluish or a colored line after the iridotomy. In a write-up with yourself and Vera in 2010, in Review of Ophthalmology, I read that the line color is described as white and sometimes as a pink or bluish tint. So it's kind of nice to put together the optics with what's happening in this case. Moving one step further, the literature also points out that patients with dysphotopsia have a more noticeable visual phenomenon in bright light. And of course, it's intuitive, but I just wanted to point it out. So when you have a very small iridotomy here, when they are exposed to ambient light or go outdoors to bright light, you're basically getting a natural pupil constriction, and the centripetal effect accentuates the dysphotopsia by pulling on that iridotomy centrally, stretching it, and that explains that phenomenon. I'm not going to go into diffraction, all that. I'm just going to focus on the tear meniscus or the tear prism, which is the crux of the issue here. Here's the patient with the exaggerated eyelid opening. which ICE has referred to as fully exposed. And when she does that, she did not find any, dysphotopsia in this state. However, in her normal resting state, it's kind of busy slide here, but I wanted to share this with you. In her normal resting position, you can see the upper lid margin here is bisecting the iridotomy here. But there's an interesting phenomenon, and the picture is worth 1,000 words. And I appreciate Brittany Richardson and the crew at Flamma Institute in Rochester, New York, for making these excellent photographs. If you look at the vertical arrows here, there is a light reflex reflecting off of the tear film. And this distance from the lid margin to the what was the outer part of the tear meniscus actually gives you what's termed as the tear meniscus height. And so what's the big deal about that? When you go a little bit to the right on the screen here, you notice here that between the lid margin and the red reflex of the iridotomy, there is a dead space. And that dead space in my analysis of this photo, and I please chime in and Vera chime in, I believe reflects the extension of that tear lake right here. And that is where the tear or the tear prism is sitting right over the iridotomy, causing her symptoms. And so that's the superior iridotomy.
I just want to maybe just make pause for a second here and maybe get Vanessa's input. I mean, I often hear that if the lid is covering the iridotomy, then you should be fine. And so, putting at 12 o'clock or whatever it is, well, why do you feel that that isn't always the case? Because, in our study, of course, we saw some patients that had coverage of their PI with the lid, right? Not everybody, but many of them did. Yet they still potentially had some dysphotopic symptoms. Vanessa, you want to give some thoughts about why we may still see this?
Yeah. So first of all, I want to give my kudos to Shakeel, because first of all, the fact that you still evaluated the whole retina, you still did the fundoscopy evaluation, even though this patient walked in diagnosing herself and telling you, when I move my eyelid, the line goes away, which was like pretty stunning. So kudos for evaluating the retina and taking care of that. But to your point, we have seen that when the eyelid is partially covering or even fully covering the PI, you still can see this line or a linear dysphotopsia phenomenon. And it's based on what Shakeel has explained so nicely, that the tear film creates this prism, and the prism bends the light, and the light will be bended upwards where the PI will be located, even though it's fully covered by the eyelid. And you can actually see it pretty nicely in his image. Even though his PI is right on the edge, on the border of the eyelid, you can see that half of it is already covered by the meniscus. So you could say it's partially covered, but if it will be fully covered, you will still get that effect from the bending of the light. And we saw that in our study, that fully covered or partially covered PIs were the ones where the patient complained mostly about linear dysphotopsias.
Yeah, and then the other thing, of course, is that our lid positions can be variable, and there's some small changes with our lid position, of course, depending on what's happening during the day or what time of day it is or our general tone. So I think that's a key point. I still hear that. Like if I can put the PI under the lid, I go ahead and do superiorly. And I think the concern is that doesn't always resolve it, because that meniscus can still bend the light. And as Shakeel said, the diffractive the diffraction of light around a small aperture, further causes bending and refraction. So it's interesting. And I'm interested to hear what you think, because there are some people who say, well, just make that PI really large, because then you actually reduce the diffraction around that aperture. I'd be interested whether people are bold enough to do that. But it's all these multiple things, I think, optically, and it's beautiful. Beautiful job, Shakeel, because optics can explain so much of what we see. Sometimes they can't, of course. And I think this is an example where it really is something that can be explainable. And it's a bit peculiar why it happens in some and not others, mind you. But maybe you might have some thoughts on that. So I'll let you see what your further thoughts are. There's another point I'm going to make up later on. I think it's coming up to talk about symptoms as well. So thank you, Shakeel.
Yeah, I'll just comment on the diffraction, although I didn't cover it, I read about it. And my understanding is that if the slit opening is smaller than the wavelength of the incoming light, then you're going to get a significant amount of, the diffraction. And if you enlarge the slit opening that is greater than the wavelength of the light, then the light will go unimpeded through that opening. But my issue is that, it's not going to prevent the prismatic refraction as well. So two components here. One is a base of prismatic effect at the level of the cornea tear film. Then you have the diffraction effect within the iris itself. So just thinking, thinking this through, I don't think enlarging the iridotomy will necessarily eliminate the dysphotopsia. It might lessen a little bit, but I'm not sure if that's a definitive solution. Vera, do you want to comment on that?
Yeah, what do you think, Vanessa? I agree with you, but Vanessa, what do you think? Would you ever enlarge the PI for that reason? Don't forget, of course.
That initially, when he showed the images, I thought the issue was in the right eye, and I thought immediately, yeah, you should enlarge that PI. When you said it's the left, it's like, okay, that's big enough. We should maybe approach this differently.
Yeah, and I agree with that. I just because your treatment's gonna maybe coverage or some sort of treatment, I certainly would be really reticent to enlarge. But we all know, of course, diffractive optics. We use this a lot with multifocal lenses, for example. The power of diffractive optics is pretty significant, and what it can do to light. And it's just something to consider with all that. So.
We've got a question here. Where do you recommend placing the PI? I know IQ said superiorly 12 o'clock. Is there consensus on that? Do you guys want to comment?
Yeah, we're going to follow through here. I'm going to address that. And
so just to be clear, I say do not put it at 12 o'clock, just so I'm clear.
Yes.
I'm sorry.
I concur. I concur with that. Yes.
We'll see what happens.
Yeah, some other groups may not agree with it, but we'll talk about that. So in terms of the study from Vera's paper, beautiful paper, I really enjoyed it, that when you have a iridotomy made temporally, sort of to answer that question that was just posed, is that light that enters through a temporal iridotomy goes unimpeded all the way, long distance to the retina. And so when the image is formed on the retina, it's actually defocused. And that's what you get from an exposed LPI. And when you see the effect from the previous one, I'm going backwards here, you can have a short distance here to see it. And don't forget, the prismatic effect is occurring with the upper lid margin. When you do it temporally, there's no lid margin interaction here to interfere with that light. So that's part of the explanation why, so anyways, the study was done to look at nuanced dysphotopsias following either superior or temporal iridotomy.
Just one more point, Shakeel, because a lot of people will say, whoa, wait a minute. I mean, that's like basically putting a second pupil, right, in the patient's iris. And there's two issues. One is focused light striking the retina, which you talked about. The other issue is just more total light coming into the eye. We've all seen, I mean, Shakeel, you repair these difficult iris defects, trauma, Flomax eyes, sometimes you see these transillumination defects after cataract surgery with this really atrophic iris, and patients come into photophobia. That's a different issue. I mean, it's still dysphotopsia, but a different kind of mechanism as opposed to focused light being focused on the retina. And we're going to get to symptomatology shortly because you kind of mentioned it earlier. Yeah. But that small PI temporally is not enough to dump all this light into the eye and cause photophobia.
Look at the photo. Look how small that is. Is there any truth to this? I've heard anecdotally, and I have not done the pathology or anatomy on this, that apparently the iris processes are much bigger or larger or taller in the temporal aspect of the eye versus nasal. And so I've heard this argument that if you do an iridotomy there, it'll be partially blocked by the iris process. And that may also explain that if you hit the iris process, why they may have more pain temporally. It's all anecdotal. I don't have any evidence.
That's interesting finding. I mean, I do a fair amount of endocycloplasty, for plateau or other causes. And now that you mentioned it, I would probably, say that maybe there is some differences. Although I also think vertically, like superiority and inferiority, they also have, you can also get more a larger process. But that's an interesting thought. I don't know if it's enough to
study, because we actually did find more pain in the patients was subjective, but they did experience more pain in the temporal eye versus the superior. So I guess if you do a temporal versus a nasal, that could be an interesting finding.
Oh, that'd be interesting.
That'd be interesting. Yeah. And of course, the reason, why do you think there's more pain, Vanessa, when we do it more temporally than superior?
Uh,
I mean, I think we just think of the long stellary nerve, right, coming across at 3 and 9 o'clock, right?
Oh, the nerve path. Yeah.
I think that we're just. I think we're just closer to that neural bundle, theoretically.
Yeah.
But yes, you're absolutely right. Patients do have more pain, and it's actually easier to do a temporal one because when you're doing it superiorly, you make so much effort to go way deep into the angle, and there's arcus, and you have to do more energy often. But here, you want to be peripheral, but you're not as like, oh, I have to get this way out in the periphery as much as you are sometime when you're superiorly. So actually, technically, I think it's potentially a little bit easier even.
I'm gonna move forward here, and so this is basically the outcome from the prospective randomized study where patients who diagnosed with primary angle closure or primary angle closure with suspects were randomized to either superior or temporal laser iridotomy. And once they were randomized, the contralateral eye received the alternate laser site. Of the 208 patients who were enrolled, 84% completed the pre-op and post-op 1-month questionnaire, and with respect to answering questions about symptomatology. And interestingly, you see in the graph over here from the paper, the majority and the main outcome was that linear dysphotopsia was significantly more with superior laser iridotomies versus temporal by a fold of almost, I think, 4-fold, 3 to 4-fold. So this is clearly an issue. All the others didn't make a difference at all. But what was interesting, as Vera pointed out, is that there was this phenomenon of even the complete lid closure of the prismatic effect. They were able to see behind that. And the take-home message from the study basically was that temporal iridotomies are less likely to induce linear dysphotopsias versus superior iridotomies. I'm aware of a paper out of Johns Hopkins in the study of South India. I'm going to talk about it in a second, but I wanted to point out, as Ike mentioned as well, that many patients don't get dysphotopsias. So I just wanted to show this red circle here that even if they're partially covered or completely covered, why aren't they having some type of experience of dysphotopsias, down the road? And there are many theories, but I did
just one point you want to make. If you go back to the previous slide, that it's funny when you actually poll patients even before doing PIs, a lot of people have some dysphotopsia, right? They've got you see glare, starburst, halos, crescents.
Sounds like Lucky Charms.
Yeah, I mean, even glare in general, you can see was present preoperatively and postoperatively. So it's interesting when you actually, and even with cataract surgery or IOL surgery, I mean, people, there's a lot of different complaints that come out. And that's why I think, dysphotopsia in general, I always really enjoy it because it's like neuro-ophthalmology. You have to kind of follow and identify where's the lesion, right? And that's why for linear dysphotopsia, here's my co-pilot here. I think with PIs, they have a very specific type of symptom. It can be generally glare and other things, but the lines and the linear dysphotopsia is what is more specific to PIs. Now, I want us to think about why is it that patients complain of these lines, usually at the lower part of their visual field, particularly specifically associated with PIs, which is different than dysphotopsia from other findings, including IOLs.
Yeah.
I don't know if you have any theories or why we see this, because the lines that you saw there, and we call it linear dysphotopsia, was what was significant here.
It goes with the optics we just talked about, right? The superior retina projects inferiorly. Why is it linear? It's probably a combination of the prismatic effect on the different wavelengths of light. And of course, with diffraction, from what I understand, you're going to have constructive and destructive interference from the diffraction that'll enhance or add to that prismatic effect of refraction to the base. And that combo, and again, I'm speaking as a layperson, allows them to see a variation in that visual phenomenon. Well,
you're not just a layperson, but I mean, I think, any thoughts from you, Vanessa?
Yeah, I just want to add that that's exactly the reason why I asked if that was the reason for the patient to come to your office to start with. Because yes, you can say if you had halos or glare, it could be intermittent angle closure, but also the fact that a lot of these dysphotopsias are present before we do anything to our patients. And it's something that if you don't ask about it, you actually don't realize. And in our paper, we actually found that some people had even the linear dysphotopsia present before. And for some patients, it actually went away after we did the LPI. And for some people, it persisted. So dysphotopsias are definitely something that you should ask your patients and discuss before you do any of these procedures, because immediately they're going to associate it. It was right after this. And sometimes they had it even before.
That's a very good point.
Really interesting point. Yeah. The reason I look at it is, I mean, we have a lid that's like linear. The lid's linear, right?
Okay.
And then the tear meniscus is following that linear, meniscus, right? That linear edge. And so I just figured that light's coming in basically, and you got your meniscus is of course linear this way, and so light's projecting in this manner. That's the simplest way I look at it in that sense. But I think it is interesting how specific that is for PIs. Not always though. By the way, Jason, sorry. Vanessa.
You show it very nicely, Shakeel, in your image. That's a beautiful image. So the meniscus wasn't just a little flash; it was a linear flash that you saw in your image.
That makes a lot of sense.
That's a good point. Yes, that's a good picture for that to show that. By the way, Jason Jones is asking because we do PIs for artisan phakic IOLs and for ICLs. Jason, we have the Evo here in Canada, so with at least myopic ICLs, we don't need to do a PI anymore, which is a benefit. Hyperopic ICLs we do, and in the U.S. where the Evo is not available, Evo is with the ICL with the small little hole in the center. You need to do a PI. And I can tell you that, I've seen some patients very unhappy, basically, that they've had a PI in preparation for doing an ICL, and they get the dysphotopsia, and especially because often surgeons do 2 PIs. So basically, they do them like supratemporal, supranasally, and that even further increases the chance of getting that lid articulation as well. That's a point I would make. The other thing I'm going to make is that I got a call from somebody saying, Ike, Vanessa and you published this paper about doing them temporally. And I think I started going temporally. And I have this patient now that has this really bad dysphotopsia. I said, really? Show me a picture of what the patient looks like. Well, the patient had a lid that was like doing this. The lid was coming down the side, right? And so you have to be watching the lid. Temporal isn't always the answer. If that patient's lid is coming across and drooping down over the patient's temporal, cornea, then don't do it temporally, because you're going to be right at the lid margin. So it's not so much important to be temporal or superior. The important thing is to keep it away from the lid margin. And so that's something just to remember, that if you have somebody who's got a lid that's drooping down, then don't do it there. Maybe you do it if you have a completely ptotic lid. Of course, you can do it anywhere, but don't do it where that lid margin is the point.
I think you're making a very important point that I think is kind of obvious, but it needs to be mentioned, that we're very good at diagnosing angle closure or appositional closure. But I'm speaking for myself. We don't bother looking at the patient in the chair before we laser them. In the ortho position, what is their resting gaze? What's the resting lid upper lid margin? And that's what I learned from these cases that I've been had to deal with.
Mm-hmm. So you can go nasally too, right? You can go nasally too if you want, and thing. And then the last thing I'm going to mention about temporal PIs, although I can't prove it, is that for some of these small eyes that have angle closure that have had LPIs, I don't know if you're going to mention this or not, Shakeel, but when they need cataract surgery, having a PI temporally, although it's probably maybe too small for most cases, maybe it reduces the risk of iris prolapse.
That is true. I've heard that.
Because you've got a PI now subincisionally for working temporally, and that may help to kind of, counteract some of that pressure behind the iris. Maybe, just a real question mark. Anyways, a lot of things to talk about. I'll let you continue, Shakeel. Sorry.
No, but I appreciate it. I love the discussion. This is great. So we talked about this, that number. I'm sorry, I'm trying to go. Yeah. So when I looked at this, too early, the divest is coming up. So when you look at these numbers here, there's quite a number of people who did not have any dysphotopsia. So I just started thinking like, how can we understand this? And so when I did my research on this and the optometric literature, I found out that there's a concept known as hopefully I'm saying it, meniscometry.
Wow.
Which is basically measurement of the inferior tear meniscus height, TMH. And what that basically does, this procedure, it basically assesses the patient's tear volume in potential contact lens wearers, because there are people who are very contact lens intolerant. So in a contact lens practice, one of the ways to assess whether or not they'll be able to tolerate this is by doing this measurement. And the TMH, or the tear meniscus height inferiorly, is measured at the lower lid, as shown here in the top diagram, with the built-in scale on the slit lamp, or one can actually take the vertical slit lamp and make it horizontal, like in the bottom here, and align it with the height of the actual tear film, and the width will have a calibration in terms of millimeters, and that will give you a value of how much that volume is. It's my understanding that the normal tear film meniscus height is about 0.2 to 0.4 millimeters. And so what's the take-home point here for me, just thinking of this out loud, is if someone has a diminished tear meniscus height, meaning they have a very insignificant tear prism, right? Dry eyes, really pencil thin tear film, that may explain perhaps why more patients do not experience dysphotopsia post, LPI superiorly. And I take it one step further, and this is my analysis. I know there's a back and forth between the Johns Hopkins group and in your practice, and that letter rebuttal in a letter to the editor. And I thought out loud that, in their practice, they did a prospective study looking at bilateral temporal and bilateral, or temporal nasal and bilateral superior iridotomies, because they wanted to, as they said it, have this visual phenomenon instead of monocularly in everyday life. But there was a little problem, I thought, based upon what we just talked about, that the South Indians, and then they also pointed out in your study, Vera, that you had a subpopulation of South Indian patients. But the South Indians who live in South India, spend more time outdoors in the sun than the South Indians who live in Canada. It's where it gets cold, right? Like Rochester. So that may explain partly why perhaps, I'm not saying it's the only one, that they did not see a lack of difference between the superior and temporal LPI. And those are obviously a homogeneous group, but just a little shout out there. I'm not sure if Ike has a comment on that.
Yeah, I mean, it is important to point out that there are different studies that have looked at this after our study as well. One of them was the Hopkins group that was reporting some South Indian results, and no question that demographics and location geography play a role, particularly in symptomatology. For example, even like IOL dysphotopsia. I'm not sure, Shakeel, if you see this, where you have patients who have temporal dysphotopsia sometimes after cataract surgery, a dark shadow, or they have glare. I mean, I go sometimes to Latin America, and I talk about negative dysphotopsia, and people say, I've never seen it ever. Never seen negative dysphotopsia. Now, maybe it's because they use different lenses than I do, different patients, different whatever. But there are interesting phenomena. But the one biggest criticism I have of the Hopkins study is that they basically randomized patients. We randomized eyes. So meaning we had a control between the patient. The patient was a control. We had an intra-eye comparison. I think that's the strongest way to study. One of the benefits we have in ophthalmology is we got two eyes. Sometimes it's a handicap as well, by the way, for studies. It's a whole other story. But having two eyes allows us to use one eye as a control. And I think that's a stronger design than randomizing patients, where we know the majority of patients are not necessarily going to have dysphotopsia because of reasons that we don't always explain, and where Shakeel has got into it a little bit. So I still believe that optically, theoretically, there's a reason why superior PIs may pose a problem. Studies like this have shown it. Case reports have shown it. It doesn't mean a temporal or nasal is going to eliminate the risk of a dysphotopsia, but I do believe that all these reasons point to it. And what's reassuring is I got a letter from Paul Foster a few years ago and saying, Ike, there's very little things that Moorfields changes because of work done outside Moorfields, right? Moorfields is a very proud institution, right? And he said, I just want you to know your study basically has changed the way we practice our PI locations. And I thought that was quite a nice compliment for the work that Vanessa had done and Devish and Graham to publish this paper. So just a point on that.
And Abdullah.
Mike, I'm going to go one step further and ask you a question, and the rest of the panel here. Why is it that we're not seeing more dysphotopsias when there's so many monstrous iridectomies with trabeculectomy? Is it because their peripheral retina is dead from peripheral visual field loss, or is it just a different alteration of the optics?
Well, it's an interesting phenomenon. I mean, I think it has to do again with some diffraction. When you have a big PI, you're not seeing that type of bending of light that can occur. And so, like I said, I think it's a matter of not just, light getting in there, it's also focusing light. And if you bend light but no focus it, then the perception of an aberrant light source is diminished, perhaps, and so that's my comment. Now, of course, if you have a monstrous PI, the bigger issue is more potentially general photophobia.
Yeah,
and that can still occur. I've seen that sometimes as well. But yeah, there are things that I cannot fully explain either, though. But that's one of my thoughts. So.
Yeah, adding to that, the just putting our imaginations, I guess, in the iridectomy has the base wider than the tip, right? Because it's a triangle, so the base where the light will bend up is even wider for light to pass and diffuse by. So that could be another reason.
Very interesting.
Are any of these studies done with shams? I wonder if people, having thought they had a PI, might experience dysphotopsias afterward. Like, what percentage of people would have that going on?
What was that, Matthew? Sorry?
I was just wondering about sort of shams in any of these trials. Like, have they ever tried that and seen if people just report them, after having thought they got one?
That's the next study. Interesting. By the way, there's a question. I'm not going to answer it, Shakeel, but basically, I'll just don't answer this right now because I think it might come up later. Pre-existing nasal LPIs have been contributed to severe mixed complications. A video at AAO showed an eye stent implantation with a nasal PI. Hang on to that thought, Laura. Interesting you mentioned that because that's something we may want to talk about afterwards.
Okay. Right. Good point. So I want to just do a shout out for Devesh. It just happened to come across. Hopefully, appreciate. I did a bit of a investigative work for this for your elite audience. And your inviting me, so I had to live up to that. So this is a interesting. The 3 months post laser, she comes. She's very frustrated, and she wants to eliminate this prismatic effect. And she basically starts joking with me, like, I'm going to sue you. She was threatening me with legal action. And here I found this memo from Devesh about how to keep lawyers at bay from ASCRS Boston, Massachusetts, 2014, where he said that patients need to be informed of potential adverse outcomes, especially with suboptimal outcome after LPI. And he challenged, I recommended the physicians to check out the internet forums to see what people are saying or patients are saying after an iridotomy. He quote unquote, they'd like to punch or hit the doctor who did the iridotomies. So I thought of her about this, like, my goodness. And then he concluded, or he more pointed out in his article, that this has altered his informed consent for the procedure. And as Veras pointed out, I think we need to ask about pre-iridotomy questions of dysphotopsias, halos, and glare. And also to let them know that if you have this procedure, then there's a small but rare chance that you may have this phenomenon that you have to deal with. So that was kind of interesting that she made this kind of threats to me more than one occasion.
All you need to do is Google PIs, and you'll see this litany of patient comments, and even I hate to say it, even suicidal ideation.
Oh my God!
Because they're so bothered by the dysphotopsia. Now we can talk all about that, about what other issues are going on, but the reality is that, yeah, man. I mean, it's something that I make sure we always have that in that list of potential risks, even with going temporal, because there are some really, really upset people out there who otherwise were doing normal. They're doing fine. They don't feel they have a problem, and all of a sudden now you're giving them a problem. So yeah, it's not a widespread issue, but it can be for specific patients.
So I think it's important when I look at interventions here that we look at it in a logical order. Hopefully, one is observation. Obviously, as the majority do resolve within time, at least 6 months, according to one study. You could come to a tinted or or shades or sunglasses to counter the sunlight when they go outdoors. And it's very interesting. I'm not sure if you came across this, Ike or Vera, about topical guanethidine. It was very interesting. There was a very large series, I think in 1966, I just saw the paper, in which they were treating patients for lid retraction from thyroid disease and how it was actually functioning to bring the lid down and constrict the pupil and relieve those symptoms. And they suggested this might be a treatment for surgical PI by inducing the ptosis and meiosis pharmacologically. Any thoughts on that, or is this anecdotal?
I mean, I think the question is the mechanism, and I presume
Adrenergic blocker, from what I understand, but I don't know the exact mechanism how it does it.
Yeah, I mean, I don't know. I mean, unless it's basically enlarging, making the PI larger because you're stretching the iris and making the pupil small, and maybe that's one reason why, again, less diffraction of light perhaps is what's doing that. But I've not used that.
Yeah, but the lid retraction is quite marked in patients with thyroid disease. So I didn't get, how it brings in about ptosis, but hey, food for thought. In terms of, at this point, any other non-surgical options you want to consider here? Matthew, you want to consider something here that's non-surgical at this point?
I don't know if you saw the question about brimonidine. I'm cheating reading that, but perhaps that could change the sort of lid position.
Okay. It's interesting. I wouldn't know. These are so rare, but that's definitely an interesting thought. But any other non-surgical options here you want to consider, Matthew?
There's also been a bunch of questions about contact lenses, colored contact lenses. So.
Okay. So cosmetic contact lenses, particularly light blocking opaque iris prosthetic soft contact lenses, are definitely an option. And so this patient indeed was offered that option. And she came in for a trial, and she was very happy, was put on. The dysphotopsia went away. She was very happy. You can see her iridotomy here in her left eye and the left side, and with the contact lens in place. So after a month's trial, the doctor gave her a particular lens size that was quite generous in terms of iris diameter and a reasonable open pupil at 4.2 millimeters, and it was dispensed. And the kind of person she is, I guess I had it coming for me. She comes back after a 14-month trial of this content, 14 months.
Trial.
Still having, well, she tried it, and what I meant by trial was she got the trial and she got the lens, and she would not wear it all the time. So it was like on and off, but it was 14 months of this journey. And then next thing I know, her husband ended up in the hospital, and she talked about driving back and forth during the day and night. And she said that when she drove, she got scared because her peripheral vision was worse when driving at night. She couldn't make out the streets, the roads, highway roads and signs. She was afraid of falling asleep with the contact lens. So she was definitely someone who wasn't really privy to good hygiene and basically responsibility of putting the contact lens on. And she basically told me flat out that this is not a long-term solution, and she wants definitive correction. And she, again, sort of gave me that giggly threat about getting a lawyer, and she's basically non-compliant with the contact lens. So what do you want to do at this point? We tried this, for her, it was not the ideal solution. She's almost 60, so what am I getting at here?
I've seen a lot in the chat talking about the corneal tattoo, which makes sense, is the next best step. I would say overall, and I like that you use the word, even though it's 14 months, it's a trial. So ideally, you want to make sure before you go to that next step that this, whatever you're going to do with, even if it's brimonidine, whatever it is, it actually helps and takes that dysphotopsia away from the patient before you take the next step.
Yeah, so we did confirm, it's a good point, Vera, that we did confirm at least that when she moved her lid, up or down, it made the dysphotopsia go away. And from the contact lens specialist, when she put it on, it resolved the dysphotopsia. So we know that this is all attributed, at least two strong cues that this is related to iridotomy. I was thinking more along the way of, if someone's got angle closure, why not just take a cataract out, right? I'm not saying that they open up a can of worms, but my thinking was that if you do cataract surgery, and she didn't pass a glare test, so she was 20/25. Sometimes following surgery, you can get the little lid droop, the little lid comes down. But of course, from what Ike and Vera talked about, it may not make it go away, but hey, who knows? It might cover a little bit and just reduce it, but that wasn't an option.
Well,
you go, Ike. I know.
no, go Vanessa, go ahead.
There's a second aspect that Ike always brings in when you do the cataract surgery. The ossification of the caps of the bag will also help.
Yes, very good point.
I totally agree. I mean, if you do cataract surgery on this patient, you're likely going to get it resolved because you're going to get peripheral capsule opacification for sure in that equatorial region. So
very good point. Very good point.
That also can do that, and there's probably other reasons too in terms of just the, how much refraction you're going to get through that area as well.
See, what I told you what you have to do is because I can read your mind.
We work together a lot.
So corneal tattooing, it's up to you, Ike. If you want to take it away from there, I do have a video from Wallace Alward. I can show yours. It's really up to you.
Why don't I quickly show this, because I think this is certainly helpful if you're not wanting to go to the OR, and use this approach. This was a patient that had that classic linear dysphotopsia with that inferior bright stimulus, and essentially what we ended up doing here. And sorry, this is the patient. You can barely see the PI. It's right up here.
Wow.
Okay. I mean, again, it just shows you it can be really small. You could look at it and you go, wow, this is really surprising. How could that cause these bad symptoms? And so what we're going to do basically is do a tattoo. What I do is I take a guarded knife. It's about a 300 micron, groove that I make right over the PI. And by the way, before that, I should mention, what I'll often do is I'll take a marking pen and just make a big mark over the cornea right here, and then see if the patient's symptoms goes away. Right, it's a temporary thing. The purple marker, medical marker we use to mark toric lenses, for example. And that can give us an idea that, okay, you know what, if I put a tattoo on, it's going to help. That's one little pre-test to do. There are different inks to use. Be careful. There are some bad players out there as well. We want to use the medical grade dye. There are different. I won't go into too much detail here, but the metallic and carbon oxide has been used, as well as a metallic. And just be sure that you research out, where you're getting it from. So that groove has been made, and then I basically take a crescent knife and I just basically dissect partial thickness cornea. And there's many different ways that have been described. Deepithelializing the cornea, using stromal punctures with a needle. I just find this one to be most definitive in my own hands and my own experience. And you want to go down at least, 1.5 millimeters or so to cover that PI enough. And then basically I take a 30 gauge needle. This is done at the slit lamp, by the way, as you can probably see, slit lamp work. And we essentially go in with 30 gauge needle, open up that groove, get it down to the apex of that tunnel, and then simply inject some dye. Some of it will go on the surface of the eye, just wash it away, and make sure it's thick enough. So stay in there for a little bit. That's why it's good to have that groove a bit longer. And that's basically it. It doesn't take long to do that. You can see the uptake there in the lamellar groove. Sometimes you have to go back and do a bit more if the uptake is not great. And this can be done in the OR as well, or a minor room. But I like working at the slit lamp for everything. So there we go. And basically that's essentially the procedure. There you go. There's immediately after. Beautiful. You can see the nice coverage. Again there, and again there. So it does work out well. I do warn the patient though that if they lift their eyelid up, that they will see this black mark. That may be potentially a cosmetic issue, but it is important to warn them about that because, socially, if they're doing anything to lift their eye up, maybe it might be a bit of an issue. So just want to put that out there as one potential. And so far our results, and I haven't done it a lot, maybe in about over the last many years, maybe about 10 patients. And all of them had a resolution. One of them didn't. One of them was partial, and we had to go back and do a little bit of an extra treatment. And I do warn them that this may wear off over time, potentially, just with cell turnover and other reasons. But so far it's been pretty good.
What's the longevity on that?
One question out of curiosity. Have you tried a different dye color in light eyes, maybe a dark blue or something?
Annalisa asked the same question. You and Annalisa are thinking exactly the same way. I have thought about that, and I've looked at different iris prostheses. The problem is it almost looks more artificial when you have a pastel color or a blue or a green that's uniform. And, our eyes that are green and blue are not like, just all green or all blue, right? And so I just haven't found, I just think it looks even weirder when you got this blue or green pastel up there. And I would worry about that aspect of it. So I haven't. And same thing with iris prosthesis. But you and Annalisa, man, you guys were, dang, the Latin
We're
connection.
women, Latinas, thinking about everything. Beauty.
So, Shakeel, why don't you tell us how you manage these patients?
Yeah, what's the longevity on the dye, Ike? Is there a longevity on that?
Well, I mean, it is tattoo, right? I mean, as you say, once you get a tattoo, right, it's there for life. It's on the skin. I think it's probably a little bit different on the cornea, just with the tissue planes we're working on. But I had one patient that came back. I had to do a retreatment. Otherwise, either they haven't come back because they just didn't want to, or it's resolved. So I can't tell you. I haven't followed these patients up for the long run.
Yeah. Okay. So I'll skip Wallace Alwards. He basically did it from the outside in. You did it from the limbus in. He did it from the cornea in. So yours seemed a little bit more, in terms of anatomy and stuff. But they both work. He did it for an iridectomy for a trab, and you can see here pre and post op.
Shakeel, I think you got to share your screen.
Oh, I'm sorry. Let me do this here in a sec. I'm trying to find, let's see, share screen. Hold on. Yep, sorry about that. Can you see it now?
Yes.
Yeah.
So basically, he did it for a tattoo over a large iridectomy from a trabeculectomy. And you can see the outcome here that's kind of sitting there, and it's a patient had the resolution of the symptoms with this approach. So in terms of interventions, the next thing that really left is we're coming to the end of this journey here is iridotomy closure surgically, and that's a definitive surgical repair. But, we just have to hold back a little bit, and I think I emphasized these points earlier, that you're dealing with a very small iridotomy. Look carefully at this, right? We talked about it. You can't even see it here in this particular screen. And then close up, you also get an arcus here that's quite peripheral, and I think will have impact. Of course, Ike, with your gifted hands, you probably can do any procedure you want. But for me, I just felt it would be very difficult to consider certain procedures. And so that was a concern for me. So I listed here in no particular order my considerations. So as Vera pointed out, very important pre-op assessment, right? If it resolves with lid movement, if it disappears after an opaque contact lens, that sort of reassures you that you're dealing with a problem that really needs to be fixed. And the other issue is that if these patients are faking, maybe not so much with the iridotomy, but unless you're really an aggressive surgeon in terms of digging into the eye, technically you can potentially traumatize the lens. One way to get around that would be to use viscoelastic in the anterior chamber and through the PI to really coat and protect that portion where you're going to do suturing, depending how big the iridotomy is. Of course, the other challenge that I pointed out already is the difficulty in accessing the surgical site. I think a seep turnout is beautiful, and I know Ike has done a bunch of this, but I'm not sure if it's really ideal, and you're welcome to chime in on this. I don't think it's ideal to repair a very far peripheral iris defect, especially dealing with a very shallow anterior chamber. It's very crowded over there, and you got an arcus. Maybe a mechanical, maybe a better option because of its shallow chamber and access to the iris and then being peripheral in terms of its approach. We also are concerned a little about risk of tearing the iris or maybe perhaps an urodialysis. So you want to make sure you have good counter traction when taking that needle bite and avoiding any kind of iris drag. In terms of the poor visualization, like in our case, it would be very important to constrict the pupil to really accentuate and delineate the iridotomy, just as when the patient's in a bright light, they see more dysphotopsias. And again, in terms of where you sit, it depends on where the actual site you want to repair. So for me, when you see this particular case, I'm going to sit temporally, depending if you're right-handed or left-handed, to really optimize your hand positioning and to provide that adequate space and also that pronation that's needed to get that needle through the two sides of the iridotomy. We talked about needle selection briefly, but curved can potentially ding the lens. A straight may be more appropriate, but it's a challenge. And last but not least, you have to let the patient know before you do this that if we fix this, you're gonna maybe perhaps get symptoms again, and you might need a laser iridotomy elsewhere, and hopefully away from the lid margin. So this is basically an intra-op photo. I call it the modified mechanical suture closure. You may say I'm crazy, and of course, it's not like I've done dozens of these, and of course, Vera can chime in. So you can see here, I sat temporally for this patient, and I felt I had to make an asymmetric entry and exit, where the entry was far away in terms of distance from the iris, because I needed that with my being right-handed, to really wiggle it in there and get in there, not hit the iris, and use a spatulated, 16 millimeter needle. Of course, I'm sure there's smaller needles, and I'm not going to disagree with you, but this is what I had to do at the point because she was really barking at me. The yellow lines indicate the entry and exit points of the iridotomy, where the white arrows basically point the entry and exit points of the needle. You can see it's a much shorter outlet here through the limbus. And pay attention to this subconjunctival hemorrhage, which is 2 millimeters beyond the limbus, and I'll tell you why that happened. Of course, this is my first N=1, and here's a video, and it's quite highly edited, but I'm going to just talk through it, so just bear with me here and try to point out some pearls here. So I basically make an incision. I'm going to vasoconstrict this pupil, because right now, look, you cannot even see the iridotomy here. As it closes, you'll see it come into being. You can just barely see it there right underneath the arcus, where I'm pointing it out. Then I'm going to come ahead and I'm going to make another incision 180 degrees away. I really want to protect the lens, being phakic, by not only constricting the pupil, but really injecting some visco cohesive, and of course the air bubble also come, but that's good. You can see there's a pouting of the edges of the iridotomy as well that'll help me to suture. I'll take in a IOL manipulator, and I'm going to assess the trajectory of my needle. And so I'm making the exit point here, and I'm going to also identify where I think is appropriate to put the entry point for this long needle. And in hindsight, I'm welcome to ideas, but this is what I thought at the moment was the best. So I'm basically going to go in there very carefully, and using the second instrument, I'm going to get in there and just try to get into that iridotomy and do some counter traction to avoid some iris drag to really get that first bite in there. You'll see it just right about there. It gets through. But you'll be surprised how long this needle is. I'm like, yeah, everything's fine here. She's under a block. You're going to see the needle doesn't come out on the other side. It comes out through the sclera. I'm not doing a Zen here, Ike. But you'll see the needle in a second popping out through the sclera. I said, holy crap, I saw the blood. I didn't know it until I saw the blood coming. If you look very carefully, you'll see the needle coming through the sclera and subcons right there. When I saw the heme start, I said, I better back up here. And she told me after the surgery, even though it was a block, that the pain that caused her was worse than her giving birth to her baby. I was okay, I'll remember that. So I went ahead, I'm really trying to just get this on the other side, and I'm feeding it through, and I'll poke it through the peripheral limbus, thank God, I'm doing very gentle here. And it's a lot of, I'm getting through now. Now this all, pretty much, coming to the home plate, make a very straight vertical incision. See, that's quite a distance, about 3 millimeters or more. She did okay. I did a dial examination there. And I inject visco cohesive as needed. And basically, I'm going to make my vertical incision here, a standard mechanical suture technique here, and use basically a Kuglen hook or a push-pull, and remove each of those free ends, and basically get ready to suture this. And as I mentioned before, the close proximity of the iridotomy to the peripheral cornea and the close proximity of the iris in the shallow angle would not cause too much of a trouble when I tug the iris when I'm closing the suture. In a way, I'm not really technically even exteriorizing the iris, you'll see here. And so it was just a very happy homecoming for me that after almost 16 months with this woman barking at me and threatening me with a lawsuit, that I finally got her off my back, and I was able to, as you can see, that you don't even see the iris coming out here. And what I'm going to do once I finish putting all the sutures in, I'll actually will sweep in between the iris and the cornea to make sure after I cut the knot, to make a knot, to cut the ends, that there's nothing there. And also the round pupil reassures me that I've done my job. And of course, I always wash out the viscoelastic manually because I don't want that to break. No need for a manual IA here. And so this is what she looked like post-surgical. Look at this. Her lid margin's up here. This is a retroillumination. It's gone. And being a glaucoma guy, or compulsive as we are, not only did you can see very carefully here, a little line over here that shows you where I closed the suture. And here's a gonioscopic photograph showing the suture material. So before someone asks me, hey, how come the TM is in good view? Because when you take a gonio photo, the gonio lens is much bigger than the cornea and causes suction effects. When you have to focus in and out, take a picture, it can artificially open up an angle that's appositionally closed. So I just want you to keep that question. I'm answering it before you ask it. And of course, I mentioned this as well. We can stop here. I can keep going. Just finishing up here, that this is not just restricted to laser iridotomies for angle closure. And as I already mentioned, there's a report in the Journal of Glaucoma where this patient was given preoperatively 2 laser iridotomies, and within 2 days started complaining of symptomatology of linear dysphotopsias and so forth. And then he went ahead 2 days later and put a iris, phakic, intraocular lens implant that was, fixated to the iris, thinking that this will get better. But amazingly, as both Vera and Ike have shown in their paper, this symptomatology got worse. By day 20, she was freaking out. So 3 weeks out, she couldn't take it anymore. So they took her back to the operating room, and they basically did a CPSR knot. And of course, this type of approach, I think, being far away from the periphery like a laser iridotomy, is much easier to access to do a CPSR knot. And kudos to them, and it resolved the issue. So their take-home message in their paper was, when you do the prophylactic LPIs for phakic IOLs, make sure that if they have symptoms, don't go put the IOL in, fix the iridotomy if you need to, then you can go ahead and put the lens implant in. I'm going to finish up here very quickly. What's the take-home message? You got to assess the lid margin pre-iridotomy. So here's a patient that came to me as well. You can see the lid margin is right around 12. I would not go supranasal or supratemporal. And with the exaggerated, excursion of the lid, you can see where it's at. So this guy's going to be a no-no if you're thinking about doing a iridotomy superiorly. And why am I mentioning this about his right eye? Because he came to me with his left eye, suffering for 7 years, linear dysphotopsias for 7 years. And he was telling me, he was threatening to sue the surgeon who did it. He said, your angles are open, it's all in your head, you're stupid, this and that, kind of talked down to the patient. And he disrespected me. He said, I did a good job. I'm a board certified ophthalmologist, blah, blah, blah. But he forgot to note that this lid here, in exaggerated stage, in this normal position, was causing the linear dysphotopsias. He was so miserable for 7 years, he was pulling his hair out. So I went ahead and did a surgery, but in this case, I did a mechanical as well. I could have certainly done a CPSR, but I put 2 sutures in. It may not look cosmetically, pleasing to me, but it's more to me as a functionality. But the take-home message was, this resolved the dysphotopsia, and he was a happy man. And I told him he might need a laser, either nasal or temporal, far removed from the lid, and he was very gracious for that. And that's pretty much, folks. I hope that was an interesting case, number 1.
That's great, Shakeel. I think we really nailed this one as far as talking about issues around PIs, and of course, indications are changing and evolving as well. A couple of things on the surgical part, I would say. I think it looks like you're using an STC6 needle.
Yeah, it's too long.
Yeah, well, you got to use the CIF4 is so much easier to use because it's got the curve. So you go through the eye, you automatically start coming out, right, as you're passing past the PI. So that probably would have helped you to kind of, follow that curve. But you did a masterful job. It's not easy. I don't know if I would want to tackle doing a very peripheral closure. I usually, that's really far in the periphery. So I think that's great. And then a small thing, which I know sounds kind of funny, but I noticed you use a bladed speculum, right? It's got a blade on it rather than the open wire speculums.
Okay.
I really find an open wire speculum gives me more freedom to move around near the limbus, because sometimes we don't realize in a smaller orbit that the lids get in the way, right? And they got a speculum now, which is metal and bladed, meaning it's not wired, and it affects the way your hands go, where your needle driver is, where your sutures are, or iris hooks, whatever they are. So I really like a wired speculum, and I use the brown speculum, which has 3 posts, so it really keeps that upper 212 o'clock lid up. And of course, as long as you have the drape draped around the lid margin, the lashes are out of the way anyway. So you don't really need necessarily that. So that's a small little tip. I know it sounds weird to say that,
Appreciate it. No, I appreciate it.
but it does. Because I find sometimes people don't talk about it. The biggest challenge they have sometimes is access getting into the eye, because you got the lid margins in the way and you got the speculum in the way. So a nice fine speculum might be an idea. So that's great. I don't know, Vanessa, if you have any more comments. I know, Shakeel, you had another case. We may have to kind of go through that quickly, just over about 20 minutes, if you don't mind.
Yeah, it's a short case.
And show that, because now that kind of ties into this case a little bit, I think, doesn't it? Based on the question we had earlier. So why don't you load up your next case, maybe? And I'm going to just, David Lockington, who's our guest speaker next week, makes a good point about using, if you did phaco, could you place a mortar iris segment? And the 96F, which is basically like a little sector shield, a modified capsular tension ring with a little black shield. I love using those when there's an iris defect, and I place them in the area where the iris defect is. And that certainly could be a very definitive solution if you're doing phaco. I agree. Although, like I said, with a small PI, often just doing cataract surgery, you have enough bag opacification of the capsule peripherally that generally ends up closing it. So anyways, great questions, great comments along the chat group. Matthew, I don't know if there's anything else that we didn't answer yet exactly. Oh yeah, this other question. Did you perform a PI in a different part of the iris? Are you still concerned about angle closure? That was the reason why the PI was done in the first place.
I mean, obviously, at that point, you have to treat them either with medications at that point, like an aqueous suppressant, or discuss with them the option of, doing a PI in a new location or taking the cataract out. So that's a discussion that, of course, they need to be followed closely like any other angle closure patient, but I'm sure they're relieved with the dysphotopsia, especially 7 years of suffering or a year and a half.
And I suspect, I mean, we often debate how big does a PI need to be. I know there's many different papers on this and discussions. Is it 50 microns? What is it? But just their needle passes themselves are creating, I think this was mentioned by somebody as well in the chat group, are creating, Alka Pandey mentioned you got more new holes to close one hole, right? With the needle driver. But I think because the iris is bunched up, it probably helps to, provide some shadow or coverage. So there probably still is some, it'd be interested to look at pupil block, whether the pupil block came back after you close the PI or not. But I suspect that it probably is still okay. And the last point I mentioned is you talked about the angle opening. I actually think when you place an iris suture in the peripheral iris, this actually opens the angle because you're pulling the iris away from the angle a little bit. And so I actually do that, for example, in patients who have very, very floppy and atonic iris, who have angle closure, take the lens out. Well, the iris still may be kind of very peripheral and atonic and may still develop synechia. I do a cerclage in those patients, and it pulls the iris to the center, and it keeps the iris away from the angle. And so it also pulls, by the way, on the scleral spur, which also opens the angle. So I wonder, actually, what you may be doing, actually, you may be opening the angle in the area where you have this suture done, and you may actually improve maybe some outflow function.
So the spectral opening, huh?
Possibly, Vivian said, is there a role for iridoplasty if the PI is small enough? Yeah, I think it's an interesting thought. I think we were debating whether enlarging the PI would be helpful or not. I think it makes a lot of optical sense. It may. The question is, how much do you need to do to make it big enough so that you lose some of the diffractive effect of the aperture? I don't know the full answer to that one, but it's an interesting question. Okay, why don't we get you to do this? I know we have about another 15, 20 minutes that we plan on. So if you could maybe share your very interesting title, Minimally Invasive Yet Maximally Destructive. Can
you see my slide?
Yeah.
Okay. So this is something I presented at all the major meetings, ASCRS, AAO, and AGS. So it was important, I think, the take-home message before I start here, really, I think it's great, it's cool. I'm not saying anything. Kudos to Ike for a phenomenal, anterior segment surgical videos on YouTube. But I think it's important for me that if I make a mistake, I want to share that, because for me, n=1 is already too much. I don't want to make that same mistake again. And what could I have done differently? So I go through a whole methodical thought process, because, to avert that kind of complication from recurring, in a future patient. So that's where I'm coming from. So it's not a cool video, it's more of an unfortunate video. So in this particular case, this patient, the question basically in this presentation is, in patients medically treated for glaucoma, who are in need for cataract surgery, and this is a question we all come across, is it necessary for them to undergo a combined Phaco plus MIGS procedure? Is it absolutely necessary? And that's something we have to think about sometimes, because I think sometimes the residents and doctors in training or fellows will think, hey, listen, you got the cataract, you got the glaucoma, why not just get into the glaucoma as well, you know? It comes along with it, because right now everything is Phaco plus, right? You know, PKP plus Phaco is PPV plus Phaco, everything's plus Phaco, right? Phaco plus, right? So here's a long story in this unfortunate woman, a very elderly, sick African-American female, poor historian. She's on end-stage renal dialysis from polycystic kidney disease. She's slumped in her chair, always nauseous in her chair. This is all hindsight, right? She's on Plavix. You know, she had a vein occlusion. She had a biopsy for, you know, temporal artery. She's arthritis. She's got tardive dyskinesia. She has depression. And on top of that, her daughter is a cancer nurse at the local institute. Oh, great. And so she basically, you know, do something for my mom because her vision's getting worse. She's on 2 medications, has dizziness. Who knows if it's from her dialysis or from the Alphagan. She's got, you know, suboptimal vision. Again, she's slumped up in a chair. She has limited mobility. Her pressures are obviously with thin pachymetry, you know, wanting a suboptimal. And they're narrow but open angles because she already had the iridotomy done. She's a chronic angle closure. And she's got, you know, so I thought about, you know, your group out there in Canada from this publication. Hey, why not put in 2 trabecular micro bypass stents and take the cataract out? You know, I'll get about an 85% reduction in meds, about a 20% reduction in IOP, and just keep her moving along for the right eye. So here's her OCT, which is, you know, I mean, nothing earth shattering here, but she's moving along. She's getting along for her needs to eat her food and watch TV. And this is the surgical video, so just watch along. I always like doing the angle surgery first, with a few exceptions. So you can see she's got the TM there because she already had iridotomy there. If you look right underneath my instrument there, my injector D, there is a prior nasal laser iridotomy. Why was it put there? I don't know. She came to me like that. So me being a perfectionist, I didn't like the way it was put in. It was kind of superficial. I'm going there to put it take another stab at this. And while I'm trying to put it in, this is the beginning of the case now. And I do all my cases topical, and I can't put her to sleep. She has a big ocular excursion, and that tip of that eye stent harpoons the iridotomy and causes a bidirectional tear, and out comes the whole iris. So I went fishing, you know, with the worm at the end of the bait, and look at that whole iris at the tip of my, you know, minimally invasive, huh, folks? Right.
Wow.
Definitely not. And it's like, you know, we're going fishing there. And it's, oh my God. I said, holy crap. So, you know, I had a moment like, what do I do here? So I went ahead and I proceeded with the surgery. The cataract surgery, thank God, went well. You know, I'm happy. That went well, thank God. And I put my lens in, everything's good. I'm saying, I wish I could just buy some time here. Let me just do some IA, and I'm gonna really superhydrate this eye and really pressurize it. And I could buy time. She probably got 360 tear and affected her, I'm sure her vasculature. Every time I try to come out, boy, she's bleeding 360. So I go in and put some Viscoat or a Visco dispersive just to coat the bleed as much as I can, the periphery, just to buy time. And I gently get the IA out. I'm just going to suture to really super pressurize that. I'm suturing it, and the tsunami is coming, right? The tsunami is coming. She's on Plavix. Don't forget, folks, another headache from me. In hindsight, that was a terrible mistake for me to have done the eye stent surgery. I could have just done the cataract. Look, the tsunami is coming. If I can just preserve a central IOL, you know, axis, she can see something, but darn it, the blood starts going behind the IOL and it's going to block her visual axis. So I'm not sure if I help by injecting that more viscodispersive here. I'm like, this is not good at all. And so what happened to her?
Actually, Shakeel, do you mind? You got to replay that for a second. I got to see that again. I'm sorry to put you through the pain here, but by the way, before you do that, could you make sure that your video is optimized for screen share?
Okay, let me end the show then. I can double check. Can I do that?
Check on that one, you know. And Jason's asking about doing the stent after Phaco.
Let me get out of here and let me.
Interesting question to ask.
Let me share screen with the. Yeah, it's not optimized for sure.
Okay, just play it again for us to see it again. I'm sorry to put you through the heartache, but it's worth watching again because that is a really crazy video there. And just as you're loading it up, Jason's asking about doing the eye stent after Phaco, which many people do. I guess the question is if you did it after would it have avoided it? Hard to know. You know,
All good questions. I
yeah,
don't know.
we do like to do it before for the best view. I mean, often afterwards is more blood reflux just because of the eye being, you know, pressurized and depressurized throughout the case. But in this particular case, it may have made a difference. Of course, not even doing the stent may have made a difference as well. So it's always one of those things that that you consider. Are you okay there, Shakeel? Sorry,
I'm looking for the video. I got it. I just need to find it. I'm sorry, I'm a little bit. I X'd out and I completely X'd out. So it's on optimal. So let me go back to the video.
And many of us do these under topical. I guess obviously the other question is perhaps somebody would have asked why not do it under block, but it's just we do so much of this topically that.
Can you see this now?
Yeah.
I'm gonna play it again. So here I'm going, it's all topical anesthesia. And I always like, why do I do it before cataract surgery? We can talk about it because that's when the patient's optimally, sedated with IV sedation. They have a gel preoperatively with lidocaine gel. And again, they have intracameral, intracameral, lidocaine preservative free. And so to me, I felt this is the best time and it's a pristine, clear view. And that's why I like doing all my angle surgeries first. Of course, my hydrous I do later on, but here, I didn't expect this to happen in her. And it just basically, it harpooned the iridotomy and caused a bidirectional tear. And it just hooked onto the iris. The iris hooked onto the tip of the snorkel. I mean, the tip of the.
Man, that's, yeah, it's a little nauseating seeing that. Wow, incredible.
My gosh, it's like a worm at the end, like, I'm going fishing here, And I always tell my residents, when you go cataract surgery, don't go fishing because if you catch something, it's over. So the cataract surgery went very well, but this is a take-home message here to that very question I asked. Is it necessary to do a mixed procedure in patients who are medically controlled, who need cataract surgery? I'm not saying she was completely medically controlled, but in her sick state of mind, with all the medical problems she had, in hindsight, I should have stuck to the cataract surgery because, again, I'm going to emphasize this again and again, the cataract surgery went well, the lens is well centered, it's in the bag, the headache is the bleed. And so I'm trying to find a way to tamponade this, and I just want to buy time. I know she'll be sick and nauseous. She's already sick and nauseous from her dialysis. I put multiple sutures here to really, close shop here. And she just basically, unfortunate set of events here. The blood is obviously, there is a tsunami taking place here. And maybe it was a mistake, perhaps I injected additional viscodispersive to keep the blood away from the central visual axis, but it made its way around the back of the IOL in the capsular bag. Now it's going to sit there. So I have to wait, before I can do a YAG cap. So I just wanted to buy time and I said, okay. And she went through a whole process here. I'm going to summarize it here. And this here, basically, look at her vision. Over a span of 4.5 months, she had a vision of LP to hand motion. Her pressure ranged from 10 to 76. She had all these procedures done. AC tap twice. She went back to the operating room 4 more times, including an emergent washout for an 8-ball hyphema and a tube shunt. Then she developed choroidal drainage, choroidal effusions requiring choroidal drainage, and I had to tie the tube. My retina colleague had to do a emergent PPV and hyaloidectomy for a malignant glaucoma. And she needed TPA injections because her blood was clotting the tube. She needed Kenalog injections because she could not take her post-op medications with non-compliance. She had multiple internal medicine ED visits, a total of 15 total interventions. And at 4.5 months, she lost the eye. It had to be removed. So I'm going to go over there real quickly, and it had to be fitted with a prosthesis. But there's a background, take-home message here as well we forgot to talk about. Minimally invasive, maximally it was not cost effective at all. I mean, imagine the cost of all of this compared to that just cataract eye stent surgery. It does not justify the cost here. So here she's at 2 to 4 weeks out. You can see she's got the pressure of 76 and a hyphema. And you can see, again, I emphasize a lot that the lens is well centered. I put a tube in. She had an AC washout with a tube shunt. And again, and here's that little plaque of blood and fibrin that trickled into the posterior capsular bag. I felt bad that she couldn't see. If she had a clearance, she would have had a chance. She had, heme in the tube, had to give her, tissue plasminogen injections, and she was non-compliant, required steroid injections. 6 weeks out, look at this. She's got almost a flat chamber with the tube up against in the cornea, and we did an ultrasound, and the retina docs found out her pressure was not out of control, but she basically had choroidals and required choroidal drainage, and the tube was tied, and the chamber did slowly deepen. But at 3 to 4 months, you can see the corneals become opacified because of the shallow chamber. The tip of the tube kept on banging up and causing endothelial compromise, and the cornea was shot over here. And so then she dealt with a flat anterior chamber. She required an emergent vitrectomy, hyaloidotomy, and ACV formation. I sent her to the cornea doc and said, listen, we can't do a PKP. She couldn't even take her drops for minimally invasive glaucoma surgery. How are we going to do a PKP? And she had to have the eye enucleated and a prosthesis placed. And unfortunately, at 10 months, she expired. And that really hit me really hard, reflecting on so-called experienced glaucoma doctor with 20 years of experience, not to mention that I've had done over 250 iStent surgeries prior to this case. So how could we have done better here? I can keep going here, Ike, or we can have a little conversation here.
Yeah, it might be good for having a conversation. I mean, I really appreciate you sharing this case. I mean, we need to learn from these examples, and they are really humbling. It's not easy to see your own complications, but let alone to share them with others. And this is really what these are about. This is kind of like an M&M rounds in some ways.
Yeah.
I think maybe you can put up some of your thoughts. And I know that there's been a lot of discussion on the chat group. I think we have to
add my thoughts, Shakeel. So yes, thank you for sharing that. I think everybody's very, very happy to see, because most people don't want to show that. And you also show your needle path through the sclera in the previous video. So definitely very, very proud of you. And you're my new idol for showing all these things for us to learn from you. So I want to say, you started with this conversation, should we always do a MIGS plus procedure in all these patients? And I agree with you. It's not a must. We need to think about it. We have to think about it as a possibility. We don't have to do it. And we definitely need to discuss that option with the patient. So I wouldn't take that completely out of the table. Yes, it's one case, but I think I would have thought and approached this patient exactly like you did. There was reasons now looking back why you shouldn't have done it, but there were also many reasons why you actually wanted this patient to stop using medications from the daughter being a nurse, and all. You had many, many good reasons to even try to put a MIGS plus or any kind of surgery to help her get rid of her drops. So don't beat yourself so hard, man. I think you did the right thing. Yes, statistics come, this happens. We have to be aware of that. But I think you did the right thing for the patient, even to start with.
Yeah, and Bruce Prum just made a comment on the chat group. I think quite appropriate. Good judgment comes from experience, and experience comes from bad judgment. So it's something we all can take home and know that. And I think, and Vivian Yip just talked about that she has had some severe bleeding even post uneventful iStent and MIGS, and so they try to stop them before MIGS surgeries. Interesting enough. So I think the whole anticoagulation one is one way to talk about it as well. But even before that, I think, as Vanessa said, we still debate the indications for surgery. I mean, we've all had complications even after routine Phaco, and we always have to ask ourselves, did that patient need to have surgery? So I think it's a really, really appropriate question to ask. I think that we all know that we do these surgeries with the best of intentions, knowing that there are rare events. This patient could have had an infection, could have had endophthalmitis, and ended up with the same result as well. Obviously, this is a question of whether there was need to do it or not. And I think there's reasonable enough data to support that adding MIGS procedures to Phaco can lower medication use. Now, probably one of the biggest, for me, findings, which is still in peer review publication process, is that the combination of Phaco MIGS does seem to reduce the need to go on to future TRABs. And I think that there's a benefit in terms of addressing adherence and IP fluctuation and better IP control when we add MIGS to Phaco. So I think that we're going to see more and more data on this. And whenever we look at cost effectiveness, you talked about the cost being very high for this patient. We always look at, of course, over a large group of patients. And I think when you add it all up, I mean, there's still some arguments to be made along that. But there's no question, there are cases that we don't necessarily need to add MIGS to Phaco, and there are cases where probably patients had Phaco done where they would have probably benefited from having MIGS with that. So this is all part of our our learning process as well. I'm just curious, maybe we go around the room a little bit talking about anticoagulants, because my approach has been like, for eye stents, I haven't stopped it because I just find the bleeding is so little and unlikely, and I pressurize the eye and it's not an issue. On the other hand, if I'm doing an abmaternal goniotomy or trabeculotomy, like for example, a GAT or KDB, I do like to stop anticoagulants, antiplatelets if I can. I don't know if you have any comments on that, Shakeel. Vanessa, chime in later on as well. What are your thoughts about just the anticoagulation issue?
That's a good question. I know I had one or two patients who underwent 120-degree KDB goniotomy, and a year and a half later, they come up with an 8-ball hyphema, and she's kind of obese and heavy set. So even in that kind of setting, you have to look at the patient's body habits before making that decision too. I think it's not just about anticoagulants. And in hindsight, I probably shouldn't have done that in those kind of patients, especially GAD as well. Sometimes hear these florid 8-ball hyphemas. So in those patients, I probably would work with the internist to see, what I can do to minimize. But again, the long term is also a concern just from positive Valsalva. So the anticoagulation is just part of the problem.
Yeah, it's a discussion we need to have. Of course, also depends on the type of anticoagulant the patient is using, aspirin versus real warfarin or something like that. But it's one of those answers that, yes, if we can afford to stop it, to your point, talking to the internist, why not? But if you're going to put the patient's life at risk for that, of course, you're not going to do it. So most of the times people just keep the patient as is. You don't want to get in there.
And perhaps someone's got really, a very tight control on anticoagulants. Maybe that's the patient you want to do the cataract on, Maybe that's the patient who do a cataract plus, I don't know, like an ABIC, where you're basically making a small incision to feed the catheter. You're basically causing a global treatment of the distal outflow pathway, and you're not really, causing tissue damage. So maybe in that kind of scenario, that might be enough to buy time, perhaps.
Yeah, I think those are all good points. And I think, I saw you mention about blocking a patient, and Jason Jones was talking about, blocking a patient that's on anticoagulants has their own issues as well, right? We've certainly seen cases and bad, orbital hemorrhages with blocking patients on anticoagulants. So there's all going to be, as they say, obviously retrospect and hindsight is 2020. It's always easy to think about that. Unfortunately, some of these things are going to be things that we just have to learn from and try to decide what to do next as far as choosing selection and also surgical technique. All very good points. I know, Shakeel, you have some other things to add, but I'm going to say that just because we're kind of coming toward the end of our rounds.
Yeah, this talk is almost done. If you just want to go over 2, 3, or 4 slides, I'm done. So it's up to you. Totally.
Yeah, but why don't you finish that? I know you had another talk that you were.
Don't worry about that one. Don't worry about that one.
I'd like to invite you back. I think you've been very open in how you share things. We appreciate. Why don't you finish off this slide set?
So basically, let me see.
And by the way, just as you're talking about this, about 5 years ago, we had a patient who had an LPI done. Otherwise healthy, no anticoagulants. This patient came back basically with essentially about almost a 3/4 hyphema. And that was pretty dramatic. Now, I think there was probably an issue. They were, when you do a PI, you get some blood, you should always tamponade the eye with the lens, sit there for a few minutes, wait until it stopped. I think the person doing it, didn't quite do all that. But just again, I mean, PIs also have, we talked about PI complications. Well, sometimes it can happen as well in that scenario as well. So tell us what you think about what you can be different. And I was actually looking for Ravi Goel. I see Ravi has arrived. He slept in on Sunday. So we always count on Ravi being here. I actually was searching for him. And I see that he's here now. I'm glad you're here, Ravi. I hope you had a nice sleep in on Sunday morning.
So this is kind of just questions that may come up. I don't think retrobulbar block or general anesthesia was an option for this sick woman on dialysis and tardive dyskinesia, et cetera, and nausea and so forth. I don't think a surgical gonial lens would have really altered the way she moved. Perhaps it would have if I used your Steve Voll's TVG with the fixation ring. I don't think a prism clip or phalange. It was just unexpected. It happened. It just happened. And the question is, could we have done MIGS after Phaco? Yeah, we could have tried that. Maybe, perhaps, that would have gotten, I could have gotten away. That's definitely an option. Or we could just on Phaco alone and continue on glaucoma meds post-op. So basically, MIGS is reserved for non-refractory glaucoma, minimal tissue alteration, which was not the case, it was maximal, high safety profile, and certainly not in her case. She lost the eye and she passed away for other reasons. And it has moderate to modest efficacy. I was just trying to move her along. And so again, as I mentioned before, when I see a complication, I do a lot of digging. I go through like, what could I have done differently? And that question comes up, what could we have done differently? And so there's a report from Chen et al. From American Academy asking that very question. What is the effect of Phaco alone on eye pressure and medications in patients with medically treated glaucoma who have not undergone prior or concomitant glaucoma surgery, meaning straight up cataract surgery? And that was important for me. So they looked at a number of studies and they regraded them to their level of reliance from level 1, 2, and 3, whether they were retrospective or prospective. And you can see here that they looked at patients who were on pre-op, they were pretty much 1 to 2 meds, and they looked at 4 diagnoses here: primary open angle glaucoma, pseudoexfoliation, chronic primary angle closure glaucoma, which our patient had, and of course, acute primary angle closure glaucoma. The biggest group of open angle glaucoma went out to about a year and a half. And what they found was that if these patients, there were 9 studies here involved with the 17-month follow-up, if these patients underwent surgery, they got a modest drop in pressure, about 13%, 17 months out. That may not seem like a lot, but if they have mild to moderate, that may be probably okay. And they had a modest drop in number of meds. But if they had pseudoexfoliation going out to almost 2 years, more than almost 3 years, they had a moderate decrease in pressure of 20%. Now, in this patient with chronic angle closure out to a year and a half, the study showed that there was a 30% drop, which was quite significant, very big drop with almost a 60% drop in meds. And this large drop, was pointed out, may reflect impaired access to outflow. And by taking the cataract out, you're allowing aqueous to go out. And this definitely, the pathology is not exclusively, limited to the trabecular meshwork. And to Ike's point, it was uncommon for these patients 2 years out to undergo a trabeculectomy, just taking the cataract out. We need to keep that in mind. It was rare at 1 year. So that's important to keep in mind. And this is a study from where they looked at cataract plus trabeculectomy in patients who had phacomorphic glaucoma, just to make a point, because we always jump the gun, right? This was done back in 2016. They had 2 groups going out about for I think 6 months, and noticed that whether they had the cataract surgery with the trab or without it, the median intraocular pressure in majority of patients was 12. Fantastic. But the visual acuity was really crappy. At 3 months, there was 62% in the cataract alone group versus about 20% in the combo trab cataract group. Again, we're missing the point that the problem was not the trabecular meshwork itself, but the outflow by taking the cataract out. Even at 6 months, look how the patients did. 75% had a great recovery of 20/40 or better. Just food for thought to keep in mind about these kind of cases. And then the last 1 or 2 slides here, you can also titrate with 1 stent. This Ike, who did a surgeon, one of the doctors from Rochester, put 4 stents in here. There's 3 of the 4, and he was very happy by that. Thanks for that, Ike. But titration by your group in Canada, they looked at 2 stents or 3 stents combined with cataract surgery for 1 year follow-up, and they basically found that they got a 20% drop in reduction in pressure. Although there wasn't an additional reduction in IOP with 3 stents, it did give another 20% less dependence on medication to 85%, almost a year and a half out. But the take-home message here is that the patient, if she just had cataract, our patient had cataract surgery alone, she would have done far better with a 30% drop in IOP, just taking the cataract out, and a reasonable reduction in pressure meds by 60%, make that cancer nurse daughter very happy and keep this woman moving along until her time came. So the take-home message for me is, in patients medically treated with non-refractory glaucoma, open angle glaucoma, pseudo-X, or angle closure, you do not necessarily have to perform a combined phaco MIGS surgery. You have to look into account the patient's patient selection is key. How old are they? What's their life expectancy? What are their comorbidities? Before considering MIGS, because nothing is 100% foolproof. What I do now with angle closure patients, with a rare exception, if they did have definite angle closure, and of course, Devesh has a whole course on how to take care of patients who have cataracts and angle closure. I perform Phaco alone, and I'll do goniosinic lysis. I had a woman just recently, I did a pressure of 62. She's 2 weeks out, pressure 11 on no meds compared to 4 meds preoperatively. So we have to man up or woman up and learn from our complications. And so I hope that this is beneficial to the viewing audience, that nothing is, foolproof.
I want to bring one more comment, Shakeel, because I have seen very similar videos to yours happening with the Phaco.
Oh my
with
God.
the Phaco piece, so it's still possible. So again, I think you did the right thing. I think there's no black and white. This is the way to go. 100% you're safe here and you're not safe here. And you did the best for that patient. So yes, every surgery can come with complications. And looking at the bright side, you did what was best for that patient in that moment. So just keep that in mind.
So my take-home message also, that tell the residents, including all of us, that there's no such thing as a routine eye surgery. The moment you let your guard down, that's when definitely something like, darn it, I broke the posterior capsule. That sucks. I get upset. So routine, they're like, what's going on, doctor? There's nothing. Now I got to do the vitrectomy. I got to put a sulcus IOL in, and patients feeling it. So I always, and for me, I'm very, very conscientious now when I go in with the resident. I don't want any distraction in the operating room.
Yeah, I mean, there's one little tip. I mean, I know it's hard. We're not in the middle of a situation, so it's really hard for us to just, say what to do. But whenever something doesn't go right, we always want to really be careful pulling out, right? Even if the eye is moving, we're better to kind of move our hand along with the eye and then wait and see what's going on. That includes with the Phaco tip or the IEA or even the vitrectomy, whatever we're doing, because that's an example of that. It's obviously very human nature, and you probably couldn't avoid it if her head moved away from you and your hand still. Then by nature, that your relative distance has increased because she moved her head. But I always say, we get patients who sometimes are moving around and stuff. I always say, like, try to move with the patient, right? A patient with nystagmus, move with the patient. I'm kind of half joking, but that's one little tip, which is obviously really hard to really do. And I think Vanessa is right. We have to learn from these things. We can't just ignore them. And it's probably going to make a difference for the next patient that you treat. But we also have to remember the patients that we have done over many, many years with success. And I think the angle closure patient, you're right, is the one that lensectomy is very effective for. But there still are some patients, and I still, for example, look to do stenting with these patients who have chronic PAS, have appositional closure for a long time, because those patients, even taking the lens out, the angle doesn't always open up. And so, that's what our consideration is for those. But it's always hard to really know exactly what we're doing. It's interesting. Alan Carlson mentioned the comment about back in the 80s, the rule of thumb was patient needed 2 or more meds to control their glaucoma and needed an extra cap, which is a temporal incision. Then the filtering procedure was included with cataract surgery. I think that's quite true. And then we saw sort of a reduction of combined phaco procedures, phaco trabs, as people got, doing more phaco alone, and where maybe some more data came out, kind of showing that phaco alone, cataract surgery alone was reasonable. And then we saw a resurgence of combining surgeries with MIGS. So I think we all have a certain threshold. We've seen kind of the pendulum swing. And I always am careful to be, too anecdotal with our results. But most importantly, man, you've shared with us, complications that can happen with otherwise what we think are relatively normal procedures, right, or routine procedures.
Yeah.
And kudos to you for sharing that. Just one last question, because David asked technically, when you do eye stents or mixed procedures, what pressure do you aim for immediately post-op? He's had a few patients where he keeps the pressure low and checks the pressure 90 minutes post-op, but he's had a few rebleeds, some reflux bleeds. What pressure do you like to keep the eye on for routine phaco MIGS or MIGS procedures?
I mean, if there's someone who requires phaco MIGS, they're not someone who are at the end of the line in terms of their glaucoma severity. So they can tolerate pressures in 20s and 30s if you have to post-op from the viscoelastic. So if you're worried about bleed, you may want to pressurize the eye a little bit, and then it's always easier to burp than to have something go wrong, right? So I'm not sure if I answered the question, but I think they can tolerate a relatively, pressure a little higher than the upper limit of normal for a little while. until
Yeah, I mean, I totally agree. I like to pressurize his eyes up to 30. I'm not really worried, and I'll be honest with you, even with more advanced glaucoma. And here's a few reasons why. When we do phaco, of course, the pressures are going pretty high in the eye, although it's only for a minute or two. If you were to see these patients and follow these patients every 30 minutes after their phaco MIGS, if the MIGS has been done well, the pressures come down quite quickly. And if you leave the patient's pressure at 18, that patient's pressure at in 30 minutes or 90 minutes may be quite low. It may be like 5, and that's where you get bleeding. So when you're at 30, the eye does not stay at 30. It will come down, especially when you do a mixed procedure. Now, phaco alone in people with glaucoma, and that is one benefit, by the way, Shakeel and Vanessa, I think if you agree with me, that phaco MIGS definitely blunts post-op IOP spike in the first 24 hours.
very good point.
It does do that. Phaco alone, if you do it on glaucoma patients, we sometimes see some pretty high spikes, even when the pressure is left at the end of the case. So the pressure you leave at the end of the case doesn't really relate to the pressure you get after a few hours. That's more a function of the outflow facility, not so much what you left the pressure at. If you've improved outflow facility because you put stents in or done MIGS, then that pressure is going to come nicely down. And if you haven't because you've done phaco alone, then be prepared. The patient may have a pressure spike, and of course, in those cases, either see them back or put them on acetazolamide or whatever else we do. So those are some important thoughts on that. So I want to just conclude here.
One more comment
I'm gonna
younger audience.
Vanessa, go ahead, Vanessa.
When you guys talk about leaving viscoelastic, can you specify how much and which viscoelastic are you leaving behind?
I don't leave viscoelastic in for eye stents or hydras. I just basically pressurize the eye with BSS. On the other hand, a goniotomy, trabeculotomy, GAT, KDB, I like to leave about a third of the anterior chamber with hyaluronic acid 1%, like Helon.
Yep.
I don't know, Shakeel, your thoughts?
Yeah, that sounds like a reasonable thing. I usually don't leave anything in unless I'm doing tubes in an elderly patient. Just my last parting comment is that from that eye stent first generation, I know we don't have that anymore unless you request it, but that applies also for the sharp tip of a Cahook dual blade or even a much larger, hydrus. That is a real thing. The hydrus is a monster. You have to be very careful what you're doing and know your surroundings and make sure it's appropriate, because those kind of devices I think are prone, as opposed to an eye stent inject or maybe a canaloplasty with ABIC.
Matthew, you're starting your fellowship
Tomorrow.
tomorrow. Are you ready?
Can you ever be ready?
Well, these are good lessons for all of us to consider. So I just want to thank you, Shakeel, so much for sharing your knowledge and your experience and your challenges that you have had. And that's a very difficult case to present and have to go through. And I appreciate it, and we'll definitely learn. And I thank the patient's family for allowing us to share and learn from all these things as well, because that's what medicine is about. As challenges.
Thanks for having me, and I really enjoyed this type of interactive session, because it makes me think, and also how each of us are, I think, in somewhere or the other, hopefully will benefit our patients moving forward.
That's fantastic, and I hope to have you back as well. And Vanessa, thank you. It's so early in the morning in California. Maybe you can take a nice little afternoon snooze while the kids are running around. But it is quiet time for you, isn't it, right now, when it's that early?
Yes, it's all great. It was fun. I love it. Thank you so much for the invitation. No,
thank you. And your paper has really changed a lot. And I do see people. I know people will say I never get a dysphotopsia in my career doing PIs. I hear it all the time. But these when it does happen, it certainly can be quite problematic to handle. So those of you who are doing PI superiority, something to think about. Obviously there's a lot of factors involved in terms of making your decisions. A lot of great discussion about how to manage them if they are a problem. And Shakeel shared some really important pearls about just thinking about MIGS and what can go wrong, what can't as well. So thank you all for attending. I'm going to close the session. Matthew, thank you for keeping us organized as well. We'll be back to see you all. David Lockington from the UK will be with us. He'll be talking about managing corneal melts and managing corneal complications and challenges. Should be really, really interesting. Bringing the cornea world in here. And we'll also have some time to talk about some tough IOL complications that are managed surgically. So keep well, keep safe. We'll see you again. And thank you all for being here.
How about a group photo before we go?
Oh, sure. Let's do that. Let's do it. Let's do a nice photo here. Everybody smile.
Spit it up though.
Hold on. Did I do it here? Hold on.
We're on the panel. You're in the middle.
Everyone smile. Super.
There you go.
Thanks, guys.
Take care, everybody. Keep well. We'll see you next week.
All right,
Bye.
follow up,
Thank
man.
you.
Bye.
Thank you.